Thank you very much, Dr. Skoshalak. As it turns out, Dr. Campos did my talk, so I'm just going to enjoy myself and tell a few jokes. What I want to talk about are the changes that we're making at the University of New Mexico in the health team. And I'm just going to use two examples. And there's nothing we do at the University of New Mexico that we haven't learned and modified from others. One of them is from another sector, which is agriculture, learning from farmers. The second is learning from Brazil with community health workers. So let's have the next slide. If you look at one health indicator in New Mexico, deaths from diabetes, and you look at the one population in New Mexico that has the best screening and treatment for diabetes, it's the Native American population, about 10% of the population in our state. But if you look at the one population that has the highest death rate from that disease, it's the Native American population. Best quality care, worst outcomes. What on earth is happening? The reason is that despite the high quality care, the amount of money we're making downstream and all the procedures, all the ERs, all of the surgeries and hospitalizations, it cannot make up for the fact that for 20, 30, 40 years, they've had the worst educational outcome, the poorest access to nutrition, social marginalization, racism, every other cause that we call social determinants that underlies why people are ill. And we're not making money taking care of that. Next. So these are social determinants. Now here's the problem. If we're going to get a lot of money, and we're now up to 18, soon it's going to be probably 20% of the gross domestic product in the healthcare system, it affects only about 10% of what makes people healthy. How are we going to reallocate that resource upstream to actually improve health? And we fight ferociously to keep that money right where it is. It's not evidence. Evidence is not going to change this. Evidence is going to be rejected if we are keeping power where it is currently. So our institution took a chance, and it said we're going to have a new vision. Next. We're going to judge ourselves by the health of our state. And this is risky. So we're going to work with community partners to help New Mexico make more progress in health and health equity than any other state by 2020. This happens to be the confirmation of the best of public health messaging, which I had never heard before we made this. And what it was is the rule of 3-9-27. No more than 3 concepts, said in 9 seconds, and no more than 27 words. That's what this is. You can actually remember this. How many of you remember the mission statement of your college? No, it gathers dust. This one you can actually say. The problem with it is that in order to achieve this, you have to move upstream. You have to address social determinants. Next. So we asked people all over our state, how are we doing? How can we improve? How can we improve your health? What is the role of the university's Health Science Center? And they gave a lot of negative answers. They said, you know, you're the University of Albuquerque. It's the big city in our state. You only come when you have a grant. Grant goes away, you disappear. You have no long-term commitment to us. You know, you don't compare very well to the agricultural college in our state. What? We compete with them in basketball and football. How can we do? And we're bigger. How can we be the ones that they don't like very much? And the reason was they have cooperative extension. They have in every single county in the United States agricultural extension agents that help those kids graduate from school with their 4-H clubs. They help improve the quality of farming. They make agriculture much more effective. They connect with everybody. That is a model that's unbelievable. So we said, let's duplicate it. We're going to create health extension all over New Mexico. Next. So what we did is we created health extension agents, put them around the state, and they conform to one of the things that Dr. Campos said. They are from the community. They live there. They're chosen by the community. We pay for them, but they have to be someone who the community trusts. And they connect with all the resources in that community, and their number one role is to look at the priority health issues in those communities and connect them to the health science center resources. In other words, our resources have to go to where the community has a priority, not our priority. Again, conforming to that mission. So if you look at one of, let's give it as an example, the biggest social determinant in our state is educational attainment. Once we had global AIDS, the fellow actually came from New Mexico, and after working there 5 years, he came back and he had this incredible insight. If he were to make one intervention that would reduce AIDS in the world, it really wouldn't be immunizations, it wouldn't be medications, it would be one thing: increase the number of girls graduating from school. That would give them more power, more say over their lives, and improved health. Next. So one of the communities we work with is on the Navajo reservation. They were tired of this endless turnover of doctors and nurses and pharmacists in their communities. They decided to grow their own. But to do that, they had to have access to information about how to become any of the health professionals, because they knew that if they could grow their own, they would stay. They wouldn't have a turnover. And so we actually worked between our health extension agents and cooperative extension agents to build this program, which is now across the state. Next. If you look at the success of health extension, their success is dependent on all of the resources locally with which they work. And that means the local colleges, junior colleges, local health systems, local sectors, education, agriculture, and everything. And so we build this, they're almost like mini health science centers. And to another point that Dr. Campos raised, it decreases social isolation to get people recruited into those fields, not just in medicine, but in all sectors. Next. The next is community health workers. Now, we've learned this system in many countries across the world, but to put it into United States health is a little bit difficult, because most community health workers have a high school education. That means they're not professional. That means they're in the community, but they're unknown to the health system for the most part. So what we did is we trained them, made them part of our system of care, and found that they were loved by their communities. Very much, again, like Dr. Campos taking my talk, they have a lot of power in those communities. Universities are seen as quite remote, looking out for themselves. And here you have someone who everyone loves in that community, culturally, linguistically competent. So we had to figure out how to put them together. Next. So what we did is we worked with managed care. And the reason we were able to work with managed care is because in the United States, for the first time, instead of managed care to me being the dark side, managed care now is putting their money into upstream prevention because it's capitated. They get a bundle of money to take care of a population of patients. Once that happens, now the investment in prevention, they make money. Every time we hospitalize someone for managed care, they're losing money. We're making money and they're losing money. So we ally with them. And they have now funded a very large network across the state. I think we're the first state that has done this heavily. But we've noticed that they have a 4-to-1 return on investment. We put them now part of our health team. They're in every single county, and now this model is in 11 states and growing. Next. So here's what we've done now. This is the next iteration that we're just beginning. If you look across the country, when we use community health workers in the United States, they're invariably used for that top 5%, those hot spotters, which is great. In other words, you can actually decrease hospitalizations and costs for people who have severe disease. And it's usually because you're involved in health literacy, getting them into their primary care system. It's great, except it has nothing to do with population health. It's saving money for the tippy-top high users. So what we said is, let's take the model, but let's have the entire population. So we just started a project with 20,000 Medicaid, capitated Medicaid recipients in New Mexico. And now we're using community health workers for chronic disease management level 2 and for the, quote, healthy population to prevent them from becoming sicker and using resources. Next. So we developed what we call a social determinants prescription pad. And this is actually, it's conceptual because this is actually on the electronic medical record. Community health workers are now screening patients with these questions, just the social determinant questions. And what's the result? Next. This is over 1,000 people walking into our clinics, community health centers, university clinics, and this is what we find. At least half have at least one major adverse social determinant. The top one, surprising to us, they couldn't pay for utilities. Well, as it turns out, there are ways of paying for utilities, but most people don't know it, and certainly the doctors don't know it. So now that you have a community health worker that's in your clinic or connected to your clinic, you can say, oh my God, here, this is the person who's going to take care of you. And you then have more compliance with medications. Patients can come, they're helping with transportation, access to food, all of the social determinants. Next. So over the years, remember back to our original vision that we're going to make more progress in health and health equity. 2 years ago, we have to use external source. United Health ranks every single state on their global health. And as it turns out, we moved from 36th to 32nd. We jumped 4 states worth. That was the 4th highest jump, because we jumped over 46 other states. So we're going strong here. It's actually possible. The contribution of the university to this is really small, but it's significant. And you can see that by partnering, you can make a big difference. So we have fulfilled the direction. And now our chancellor talks to me every month, says, 2020 is coming rather quickly. Are we really going to? I said, I don't know. That's the North Star. Let's just keep moving. So thank you very much.
Thank you, Dr. Kaufman. David Asprey.